welcome to the IMWG Conference Series, reporting this time from Stockholm, Sweden. We're very, very pleased to be here. We have just moments ago finished the IMWG Summit over the last 2 days. We have had meetings at ASCO a week or so ago, and we're heading into EHA. And so what we're going to try to accomplish is to make sense of treatment based upon input from those three venues. And I'm very, very pleased that joining me, Brian Durie here. I have to my immediate left Joseph Mikhael from the City of Hope Cancer Center, and now the Chief Medical Officer at the International Myeloma Foundation. Very, very pleased to welcome Joe today.
Thank you, Brian.
And very pleased to have Sagar Lonial from Emory University in Atlanta. So we have very, very good input to try to make sense of what we're going to talk about today, which are 6 topics which have been heavily discussed, particularly at our summit, but also at ASCO and coming up at EHA. And so something completely new is the role of mass spectrometry. So the first thing for a broad audience, and actually, frankly, for most of our IMWG members is, well, what is mass spectrometry? And so spectrometry, in this case, based upon the mass or the weight of the proteins. And what that means for monoclonal proteins is based upon the weight, like lambda and kappa. One can distinguish the mass of lambda versus kappa in a very, very specific way based upon the mass or the number of DA Daltons, which is an expression of the weight. And so using a workflow lab, this will transform a lab into a mass fix, the fix meaning immunofixation. Instead of using immunofixation, it's going to be possible to use this MALDI mass spec machine. This MALDI is the type of automated machine that will handle the samples coming in, and then there will be a readout that will allow us to see the presence or absence of these monoclonal proteins, and it will be a whole new reference system for the lab with a different workflow, which will be much, much more efficient and also much, much more reliable. And so there is a transformation coming to the initial detection of myeloma, the monoclonal protein, the immunofixation, and this is going to have a big impact in the way that we diagnose and follow patients with myeloma and MGUS and smoldering myeloma as well. So just to show you, this is what it will look like. It will be possible to see a spike on the mass spec, which is the myeloma monoclonal protein. Separately, we will be able to see treatments which are also proteins, such as daratumumab. And you can see here that if there's daratumumab being given, that you can see as you give the daratumumab that the myeloma protein is going down. And a response to daratumumab will be evident in a very precise way. One can also look at the proteins over time, and what is seen here is when you follow the proteins at a very, very deep level, so if you're looking at the deepening of the response, when you go to a very deep level, there are patients who continue to have absence of the protein even at a deep level, and then when you go deeper, if the protein is present, those are the patients that are liable to relapse early. And so it will transform our ability to understand response and relapse. So this was going to be a technology that will really impact the way that we look at patients. And another important aspect shown here is diagnosing MGUS. This is a patient with MGUS in 2006. Back in 1997, there was no immunofixation spike. When the sample was tested with immunofixation, with mass spectrometry, it turned out that in fact there was a spike there that was evident back in 1997. And so we are going to be able to diagnose these early disease patients, MGUS, much, much earlier. It's going to allow us to understand the evolution and the biology of these earlier disease states. And so more sensitivity, a practical commercial method, identification of monoclonal antibodies used for therapy, it will change for sure the diagnosis and response assessment. And so Joe, perhaps first you could say, well, what do you think is going to be the impact of this?
Well, thanks, Brian. I mean, you've summarized it so well. I mean, I think for patients listening in today, you know, one of the challenges that we have with myeloma is that although, you know, the immunofixation methods we have now and the serum protein electrophoresis and even the light chains can be quite accurate, they may not be as accurate as we think they are. Between labs, there's differences. I know a lot of patients would come and say, you know, Doc, how is my M spike here 1.3? I just had it done last week at my other doctor's at 1.6. So it's really going to, I think, give us a more accurate measure of someone's disease. Remember, myeloma is a protein disease, and so the best way we can measure a protein will be helpful for them. I think it'll also help in that we'll be able to detect even smaller amounts of the disease coming back, as you've shown, than before. We used to have to wait until it was maybe a bit more crude method. Now we have a much more precise way of doing so. So I think for the patients listening in, I got to have a better assessment of my disease. I got to have a better way to pick up my disease when it comes back. Of course, there's all the benefits in the lab. It's going to happen more quickly, but that also can benefit the patient too. Some labs take 2-3 days to do the serum protein electrophoresis and all of the ongoing tests with it. With mass spec, even though it's going to take a while for labs to implement this, once they have it up and running, this can have a turnaround time easily within the same day.
Oh, yes.
But I think it's going to take several months, if not years, before this will be available to all the patients listening in today. But in the short term, we're going to start to see it already have an impact.
Yes, it's going to be a rollout over the next couple of years or so, where it'll be available as a experimental test and then a commercial test maybe a couple of years from now. So what do you think, Sagar?
Yeah, I mean, I think it's pretty clear consistency and convenience are two definite advantages of mass spec. I like the idea of being able to know within a Dalton where your protein is and then compare it to others. And I think from a future research perspective, the ability to know what the background other proteins in a patient with MGUS, for instance, as you showed, may clue us into the risk of progressing to myeloma, where you may lose that background, as opposed to a polyclonal spike where you know that background predicts for perhaps a better outcome. So I think there are lots of opportunities.
Yeah, understanding that biology of the evolution of the MGUS, I think that there's a lot that we don't know right there.
Yeah.
Okay, so I think good points. So we're looking forward to this, and this is the first time that it's really been discussed at any kind of a major meeting, and I think everyone was kind of excited just to understand the status of this testing.
Maybe just one other thing that I'll add, Brian, is that as we're incorporating more mass spec testing in the clinical trials that we're doing, in particular the screening trials, I think are going to be important. You know, a number of us are involved in these kinds of studies where we want to test large populations of patients. You know, obviously here at the IMF we do this amazing work in Iceland trying to screen huge numbers of patients. That instead of just using the traditional test, now we're adding mass spec to it. That's going to give us a deeper insight to better understand, as we said, the biology of the disease and the research questions that come from it, but even being able to detect it at lower levels. You know, we had a good discussion here at the summit. Does this mean everybody in the world has MGUS now if we look really carefully? Well, no, not everybody in the world has MGUS. But the incidence of MGUS will likely go up a little bit in the sense that, not that the incidence itself has changed, but our ability to detect it has changed. And that gives us confidence to say we can really know if someone has it or not, because there are examples like the one you gave where someone may have been told, oh, no, you don't have MGUS, nothing to worry about, when in fact the patient might have it. So this will allow us to detect that more carefully.
Right. Well, in reviewing normal people, the increased occurrence of spikes was only increased
1.5 or 2%.
About 1.5, 2%. So I think that we don't need to be too worried about picking up a lot of extra spikes. And so when we find a spike, it probably is going to be meaningful. And I think that is very exciting in Iceland to understand how many more cases of MGUS might be picked up. And also the age distribution, when do those spikes occur? And we're interested to learn maybe what's causing those spikes to occur, whether it be in the setting of a particular genetic pattern or other environmental or social factors that are contributing to that. And then also an opportunity for early intervention.
Yeah, and I think, you know, particularly one of the challenges that we face now is the light chain escape or the oligosecretory patient.
Yes.
Using the free light chain assay sometimes give you some clues into how to follow those patients, but this may be a much more precise way to deal with that, which often occurs in later lines of therapy.
Absolutely. So this can precisely tell you if a spike is an oligoclonal or a little bit of the original M spike. So very important.
And that may have real implications for some patients who now, with the current testing, they may not be eligible for clinical trials, or we may not be accurately follow their disease. If we could do it more accurately, that might allow them to have greater access to other treatments.
Absolutely. Okay, so I'm going to move on to the second topic, which was also a full session here in Stockholm. And I'm just going to give an overview of the status of MRD testing. I think that obviously we're pretty familiar with MRD testing now. We have the two methods that can be used. We've learned for sure that sensitivity at the 10 to the minus 6 level, the 1 in a million level, that really does make a difference in terms of a better PFS and anticipated survival outcome. And so trying to get to that level is definitely important in a clinical trial setting. What we also heard is that there's a pretty mixed perspective about how we should implement this in our clinical setting at the present time. And so I think we can probably just jump straight to the questions here, the key points. So as far as clinical trials, Sagar, how do you see the impact of MRD testing in clinical trials right now?
Yeah, I think there's no question that MRD has pretty important prognostic implications. Patients that achieve that level of depth of response have better PFS and long-term overall survival. I think how do we use this further on to make changes in therapy is really a subject of big debate at the meeting in the last day or two. And what I thought was really striking was the level of discordance amongst our members.
Yeah, 50% split actually.
Right, which was I think speaks to the level of evidence we have to support its use one way or another in terms of decision making. One area where I've got a little bit of concern in terms of interpreting outcome data with MRD really revolves around how patients were maintained in many of those trials, because we know that maintenance can impact PFS and OS potentially independent of MRD negativity.
Absolutely.
So, for instance, if you've got a high-risk patient that may not be MRD negative, but they're on a U.S.-based risk-adapted maintenance, like RVD, for instance, that our institution has piloted for a while, MRD may not mean the same thing in that patient as it does a patient in Europe who receives Len alone as maintenance with high-risk disease. So I think we have to understand some of those subtleties.
Yeah, I think it was pretty clear from my listening that people are uncomfortable to start to make big decisions based on the testing as of now. So what do you think?
No, I completely agree. I mean, I think it's critical that we do this kind of testing so that we can better, almost like mass spec, right? If we can diagnose the disease more accurately, follow it more accurately, and now we can more clearly assess how deep someone's response is. You want to know that their disease is gone down to that level. But I agree, there's a tremendous danger of making major treatment decisions until we know, even if it might predict that someone's going to live longer, which kind of makes sense. The deeper response you get, the longer it should be. It doesn't necessarily mean that we want to make a change in treatment. You know, we know about 15% of people who live the longest with myeloma. I mean, it's not majority by any means, but 15% of those people actually never even get a deep response. They go back to some kind of MGUS-like state. So we want to be careful, because I think the danger is we can either over or under treat these people. We might say, oh, you got MRD negativity, great, let's stop treatment, when in fact maybe that patient really needed it. By contrast, we might say, uh-oh, you're MRD positive, you need more, you need more, you need more, when in fact maybe they just need to stay on what they are or less. So I was actually encouraged by the end of the summit with the discordance that, you know, I asked that audience question and people were totally split on it. But I think by the end people recognized that we have to do trials that whatever depth someone gets to, then we randomize to the two options of either going on to something different or stopping, and then looking after. But I'd be worried if a patient listens today and says, well, You know, I listened to Dr. Lonial and they said I'm MRD negative, so I can stop treatment now.
No.
I don't think we're ready to make those kinds of decisions.
So I think it was very encouraging for everyone to see the menu of trials where there was randomization both for MRD negative and positive. As you say, MRD negative, maybe those patients are responding, need to stay on treatment. And then MRD positive, we're not quite sure what to do.
Yeah,
really.
I mean, I think it's sort of we're a victim of our own success to a certain extent. I mean, you remember the SWOG criteria where CR was a 75% reduction in the M protein, right?
Exactly.
We've gone 180 degrees in the other direction, saying now 1 in a million is what we really are shooting for in many patients. I think the other piece that was brought up very nicely in the discussion by the working group was the importance of imaging as a partner to MRD detection.
Absolutely.
Because, you know, as Bart has been saying for years, it's great you're making the M protein go away, but what else is happening that may not be making a protein?
Yes, yeah. The combination with the PET CT in patients who may have extramedullary disease, yeah. So that comes around to, so how are you using this in clinical practice in the meantime, Sagar? What were you doing?
Yeah, I think we're collecting data right now and trying to analyze it in the context of a risk-adapted maintenance approach and what does it really mean. At least I'm not using it for immediate decision-making processes. Particularly, I think one of the concerns is just because you've reached MRD negativity, almost all the trials we've looked at don't necessarily show a plateau, meaning that you've achieved a point where you can stop therapy reliably.
Right.
And so until we have that data, I'm a little hesitant to use it to make a decision.
Right, right. So do you feel the same way?
Yeah, no, actually I feel identical. I mean, very much so. We collect it so we can have a big database and then later on look back. But I think it's very dangerous to make a treatment decision. Now, we kind of make treatment decisions based on depth of response already. You know, if someone, let's say, has had their transplant and you're getting ready for maintenance and there's still a lot of disease there, you might approach that differently. But I think when we're down to the level of MRD negativity, if I've got someone who's in pretty well a complete remission or close to it, whether they're MRD positive or negative, it's not going to change what I do. And I think that's important because otherwise we're going to be hurting our futures by making these decisions and not be able to look back and objectively know, was that the right decision or not?
Right, right. I do hear more decisions being considered when patients are MRD positive. And I think that the opportunity to maybe study and change treatment is there maybe a little bit sooner. We'll be able to make those interventions.
Sure.
And now as we tend to be treating people longer, it's you know, part and parcel of that same discussion. Like we tend to in the US give maintenance for all the time until someone relapses, unless of course they have real difficulty with the drug. Whereas in some of the European countries where they may stop at a certain point, that's where that MRD positivity may influence them to keep them on it longer. But I think in general, we're treating most patients after, at least after transplant, until their disease comes back.
And some of this relates to the treatment at symptomatic relapse versus treatment at biochemical relapse.
Yes, yes.
This takes that whole question to another level where just because somebody goes to 20 to 50 copies, are you going to start treating them now or change their therapy? When we're not even sure, and that was another discordant discussion in the working group, whether biochemical versus symptomatic relapse is the right time to go.
Right, right. And actually, we're pretty excited. Within the Black Swan Research Initiative, Alberto Orfeo, he presented data about studying cells in the blood, and he showed data for the first time that if you have clonal plasma cells in the circulation, even in a patient who's in complete remission, that indicates a shorter remission time, and you would be, with that information, more comfortable to intervene early, because you know it means something.
Right. Yeah. Right.
Okay, so let's move on to what was probably the biggest discussion at this meeting at ASCO, and I think also will be upcoming at EHA. Where are we with cellular therapy, particularly T-cell therapy? The first thing to be said is that as we talk about CAR T-cells, we're focusing on what will end up being a spectrum of cellular therapies, I believe. But for now, at least, there's a big focus on CAR T-cells. Obviously, with the different generations of creation of these CAR T-cells with different molecular surface antigens and internal co-stimulation, signal 1, signal 2, and so The first thing to be said is that with all the different technologies, there are different types of CAR T cells. They're not all the same by any means, and so this is an issue in terms of interpreting the data. The logistics for patients looking in, this is basically a procedure similar to transplantation, where on the left you have the cells removed, you have the creation of the manufactured CAR T cells with a particular target on the surface of the cells, then the culturing of those cells, and then the reinfusion of these cells. And you can see right off that there could be some variability in this preparation process, which takes 2-3 weeks. And so a whole different concept of therapy, not where you go into the clinic and you get your chemotherapy at 2 o'clock. Very different. You might come back a month later if it's all set to go. We have several trials focused on the BCMA CAR T cells, so the B cell maturation antigen, which is rather universally expressed on myeloma cells. So the 4 groups of trials targeting the CAR T cells against the surface antigen, the Memorial Sloan Kettering, UPenn, BB2121, and the LCAR, which is the Legend trial, which was presented at ASCO last year, actually. I'm going to focus particularly on the BB2121, which was presented in update form at ASCO, and a lot of interest in that, both in terms of the efficacy, very high response rate, a lot of attention to what was the safety in this trial. I think that there was a reassurance that only a small number of patients had the cytokine release syndrome, the rather dangerous side effect that can have neurologic side effects, for example. So many patients had lower levels of cytokine release syndrome, but only a few with the higher level. So a lot of enthusiasm about the efficacy, with the hope that the toxicity would be manageable using steroids or other measures to control what is going on. I think that there was a big focus on what is the depth of response with this therapy, and this is showing here that with the different levels of dosing, if you give more cells, you get a better response and perhaps a deeper response. But I would draw attention here to this footnote. There are 2 things about looking at MRD in this setting. The first thing is that the MRD occurs very quickly, and we're really unsure how to interpret that because we're used to measuring MRD, which occurs progressively over time. The other thing is that we do need to look closely at what is the level of the MRD, and most of these were at 10 to the minus 5, only a few at 10 to the minus 6. One was at 10 to the minus 4. So that when you say MRD negative, you do need to look at the footnote down here and see what was the level and what was the timing and how are we going to interpret this. But I think the big thing that was discussed at ASCO was these are heavily, heavily pretreated patients who've had many, many lines of therapy, and what do we think about the fact that the average remission time is 11.8 months? Is this good? For patients who have deep responses, perhaps a little bit longer. And so I think that a lot of enthusiasm, but also thinking already about what's happening in terms of why are these patients progressing or relapsing, what kind of things are going on. Will this be a therapy where it needs to be combined or maybe repeated, where you give one infusion, maybe you'll need to give another infusion to do a better job? So a lot of questions. So questions about how will we give the CAR T cells, how well do they work, and what should we be aiming for in terms of our goal relative to other therapies that we have. And so maybe I'll just stop with this slide right here. A lot of questions about CAR T cells. And so, Sagar, maybe you want to go first. What's your perspective on the status of CAR T cells right now?
Well, I think, our lymphoma colleagues and ALL colleagues were ahead of us, but I think we've rapidly caught up and maybe even ahead of them a little bit to a certain extent. I think the data that we saw updated at ASCO on BB2121 is really very exciting. 11.8 months, basically a year for median PFS. If you remember back to the days of bortezomib in that same patient population, PFS was less than 6 months, carfilzomib less than 6 months, daratumumab less than 6 months, and now here we are at almost a year. If you compare it to the lymphoma CAR T cells, it's 4 times longer than what was seen in the...
So much better in myeloma.
Yeah. Now, the question is, do we have a plateau and a tail on the curve, as we've seen in both ALL and lymphoma? And it's probably too early to know, but I think that's certainly one of the important pieces of information that we hope to get in the next few months.
Right. And Joe, what do you think?
Yeah, no, I feel similarly. I mean, I think what it's done is it's all the hype that there was around CAR T-cell therapy. In one way, it validated it, to take a patient who, even the presenter, Dr. Rajay, was telling us yesterday, I mean, a lot of these patients were sadly literally on their way to hospice. Like, they had just no other options. They exhausted every option. To give those patients, on average, another year before they progressed, let alone overall survival, I think is very exciting. I think, on the other hand, it's also a reminder that it's not a cure-all either. Right. That there were challenges with the drug. Not everybody responds. There are relapses. Obviously, we'll talk more about the types of relapses and what we do for them. So for me, it was. I mean, I agree with Sagar. This is definitely going to be, I think, a part of what we do in the future. But I wouldn't want people to get the sense that this is the cure-all for everybody, and once someone has CAR T-cell therapy, they won't need anything else. And in fact, now we have an interesting cadre of patients who have relapsed on CAR T that we're trying to figure out what's best for them thereafter. But I was very encouraged by that 11.8 months. I mean, that's by far the longest progression-free survival, or PFS, that we have seen in any CAR T-cell therapy in myeloma.
Right. So
I do think it's worth addressing the CRS question. So
the toxicity.
Yeah, you raised the cytokine release as a potential adverse event, and at least in my mind, I think about it as similarly to tumor lysis syndrome, where you have highly effective therapy, and you just have to know how to manage and mitigate that.
Right.
Now, it doesn't mean that CRS is something you ignore or take with a grain of sand, but there is certainly an experience factor at a center in being able to deal with CRS.
Right.
And I don't think about that as a reason not to use a CAR T cell.
Okay, yes. And so then there's still a uncertainty. If you have a lot of CRS, is that a lot of reduction in tumor burden? Is that actually a good thing,
Right.
So it's not necessarily something to be completely avoiding.
Right.
But look how far we've evolved.
To modulate.
Yeah, look how far we've evolved. I mean, in that first trial a couple of years ago that we discussed at one of our conference series, out of those first 9 patients, 6 of them went to the ICU.
Right.
So now we're seeing, dramatically less than that. So that's encouraging.
Yeah, and whereas now, I think with grade 1, certain types of grade 1 CRS, we're giving TOSI early rather than waiting for them to be in the ICU before we give it to try and preempt it, and that may be important.
Right. And so one of your colleagues, Jonathan Kaufman, he said that this is not just CAR T-cell, but it might be the Model T, and we need to wait around for the Maserati to come along. So do you think that, we're just at an early stage in having the final kind of CAR T therapy? Yeah,
absolutely. I think this is our first foray into it, and we're all trying to figure out what's the best construct, what's the best cell type.
Yeah.
I think there are manipulations to the source of cells.
Right.
So are there things you can do to patients to manipulate their T cells prior to collection?
Right.
Are there things you can do in vitro with the T cells to make them more effective? And are there things you can do to the host after reinfusion that may give you longer or better longevity
to sustain
of the T cells? Yeah. So I think those are all variables we're starting to deal with.
Right. And so we don't need to talk about this too much, but the last thing I have here, number 4, I mean, the cost, the logistics and the cost, I think it is certainly going to have an impact in terms of how this rolls out.
Yeah.
I think it's, when I look at this, it's just a little too early to determine that, because one, we haven't worked out all these kinks, as it were, where I think it will get smoother and easier and potentially even cheaper. And then, of course, in the long term, there is this concept of off-the-shelf CAR T-cell like therapy.
Absolutely.
It may not be the exact same where we take someone's cells, manipulate them, expand them and give them back. Maybe we can have an off-the-shelf like approach, which may affect that. So I'm not burying my head in the sand of the cost, but there has been, I think, a little excessive hype around the cost of CAR T-cell therapy. Obviously, any new therapy is going to be particularly more costly until we work out the details. But I look at this as going to be another excellent option for certain patients, but probably not universally across the board. Obviously, we'll have to see with time where we use it. If we're only using it in that very heavily pre-treated patient, or might we be bringing it up earlier in treatment?
Right. If you bring it up earlier and it has a decisive benefit, you know, our therapies, our current therapies, combos are $200,000, $300,000, $400,000 for a combo for a year. And so if this gives earlier in the disease a multi-year benefit, then, you know, the cost-effective ratio is good.
And I think, you know, I think all of us are beginning to explore the idea of, with multiple highly effective agents, and CAR T cells are one of them, that the duration of therapy question is one that we're beginning to ask.
Right.
And so if you want to talk about cost benefit,
Yes.
if we can stop, then things all of a sudden have a very different cost benefit ratio.
Absolutely. And right now with our current therapies, that maintenance seems
Right.
to be quite important.
Correct.
And that cost is there.
Right. Right.
Yes. So a follow-on point is, what about the other ways of targeting the BCMA? And we didn't talk about this too much, but obviously with the GCK product, monoclonal antibody armed, quite good responses, not quite as good as with the CAR T cells. And so, Joe, what do you think about this? Where do you see those fitting in versus the CAR T?
Yeah, I mean, as a myeloma doctor, I want more options, right? Because
Yes.
every option could work better in a different patient. I'm excited that CAR T cell therapy, as Sagar was saying, is not just one kind of model.
Right.
You know, you want different, you know, not to push the analogy too far, but you want different cars for different trips, right? Sometimes you want the bigger van, sometimes you want the smaller sports car, or however you want to get there. So actually, I do think that the antibody therapy, which you showed directly hitting BCMA, could actually be almost like an off-the-shelf like approach, as we've said, where there isn't all the manipulation of CAR T cell therapy. And I'm actually quite excited about these bispecific antibodies, or this notion where an antibody not only hooks onto the tumor cell, but hooks onto one of the cells or something in the immune system and engages the immune system. So leveraging this concept that now we use so extensively, antibody therapy, with some of the concept of CAR T cell therapy, it might be one that's a little bit easier to administer, doesn't involve all the cell processing, because we think about the sheer number. I mean, if we have problems doing auto transplants in some patients because of access, doing CAR T cell therapy could be a challenge too. So I don't think this is going to replace CAR T cell therapy in some ways. I think it's going to be, again, where you match the patient, the disease, to the best approach possible.
Well, one thing that I picked up on at our summit here was it's going to be a lot easier to combine these antibodies and with other therapies. And so I was encouraged to see trials coming along with a combo approach where it's a lot easier to do that.
Yeah, and I think, you know, one of the current challenges with CAR T cell therapy is the gap. What do you do between when you've collected the T cells and when you want to infuse? And many of the current patients, that's a long time to go with nothing.
Absolutely.
And many of them have seen a lot of therapy, so the options are not great anyway.
Right.
And so I think whether these bispecifics or antibody drug conjugates can be bridges. You know, I think it would almost be really interesting to think of them as a test dose. If you respond to a BCMA-directed therapy, it's a predictor of a responder to a CAR T cell. So it would be really curious, again, from a cost perspective, and I'm just sort of thinking through it, if you don't respond to a BCMA-directed non-CAR, will you respond to a BCMA CAR?
Absolutely.
And that may be a way to say, maybe your benefit's less. And
Right,
we need to
and
think about
there was some
something else.
early discussion about that. We really don't know at this point which patients are likely to benefit the most, and if we did know that, it would be hugely helpful.
Yes, right.
Okay, so let's move on to other new therapies, of which there are a lot. On my first slide here, I've just kind of listed some of the new drug approaches that have been presented at ASCO and here, and will be also, some of them represented here at EHA actually. And so we have combinations with approved drugs, Kyprolis, Dara, pomalidomide, and then the pre-approved, well, we're hoping that these would be the next drugs that would be eligible for approval, selinexor, venetoclax, and isatuximab, and more 202, both of those being other alternate anti-CD38 monoclonal antibodies. So if we just go through a little bit, As far as the approved drugs, I think there was tremendous interest in the paper presented by Mary V. Mateos at ASCO, where she was looking at a once-a-week, a higher dose of carfilzomib versus a standard twice-a-week dosing. This was the comparison, once-a-week carfilzomib plus dexamethasone versus the standard in the yellow here, the lower dose, standard dose twice a week. And I think that it was a pretty decisive result in terms of both overall response was better with the once-a-week higher dose, and then also that the remissions were a little bit better with the once-a-week dosing. And I think surprisingly, people were interested in what would be the toxicity. Toxicity really quite acceptable, well tolerated. And so I think that there was, I would say, a little bit of surprise, but a very positive surprise about these data. So, Joe, what do you think? Will we be switching to once-a-week carfilzomib now?
Well, I mean, I don't think we'd be switching necessarily everyone, but we've been doing it already.
Yes,
I mean,
yes,
from
that's
some
true.
of the earlier studies. You know, the point here, of course, is a lot more convenient for the patient. So to come in 3 times in a 4-week period instead of 6 is very attractive. I mean, even if the results had been even, I think people would have been happy, let alone by getting a higher dose of carfilzomib more conveniently, it actually seems to be better for patients. So I wouldn't say, you know, you're going to do it and you're going to like it, like you're going to make everybody go to once weekly, but actually I think this will be a step in that direction. Be interesting to see if it can ultimately, from a regulatory standpoint, influence how we do future clinical trials with carfilzomib.
Right.
Because that has been sometimes the difficulty,
being a problem.
especially combining it with other IV treatments like daratumumab. But I'm, because this isn't the first trial ever in this is the largest one, but because we've seen the precursor studies, I actually believe in this. I think going to once weekly, I've had many, many patients who we've gone to once weekly. Very few of them want to switch back to twice weekly. Right. There is the occasional patient that may not feel as well. And then lastly, I was also encouraged, as you mentioned, that there really wasn't, it seemed to be not a big toxicity change. That you know, one of the concerns
for cardiac and the like, really not a cardiac signal.
Right, and that's something we've been monitoring pretty closely, that there's always been about that 5% of patients that seem to have some kind of cardiac issue with carfilzomib. Thankfully, only 5%, but still an important 5%.
Right.
And that number didn't really seem to change when we went to once weekly.
It's still in the same range.
Yeah, I think it's interesting, and I think going to weekly dosing is something obviously our patients really want, and it's nice to see the efficacy. I think to me, the other take-home message about this was that, and it's not paid attention to as much, is that the 2027 dose looks, in terms of PFS and response rate, identical to bortezomib. And I think when we think about carfilzomib as being more potent, it really is the higher doses that get us that potency. The 2027 may be very similar to bortezomib in terms of efficacy, clearly much, much lower peripheral neuropathy.
Right. Okay, so let's move forward. Just into some of the other combination studies, it was interesting to see carfilzomib combined with venetoclax, and so venetoclax is the BCL2 inhibitor, which is moving forward in clinical trials. We have responses in refractory disease. We obviously have data based on cytogenetics, where the efficacy is very good. Obviously, with 1114, patients with high cytogenetic risk. You can see here, obviously, 1114, the best outcomes. So I think that we're certainly anticipating with this level of efficacy that venetoclax will be moving forward, hopefully for approval in some setting. So Sagar, how do you view this pathway? Will it be for this preferred group, the 1114 with the high BCL2 expression, or maybe more broadly? What do you see?
Yeah, I think that's a great question. Larry Boyes at our group has done a lot of work on predicting sensitivity to venetoclax in myeloma, and whether it's the ratio or the expression or simply dependence on BCL2, which actually in vitro seems to be the best predictor.
Yes.
And almost all of them are in the 11-14 group, though not all 11-14s are sensitive. And from in vitro analysis, at least, it appears that the best partner for venetoclax is dexamethasone. And as an example, at this meeting, there's data that's being updated by Jonathan Kaufman on venetoclax plus dex in 11-14 positive only myeloma. And the last time he showed the data, the response rate was almost 70%.
Okay.
So that's pretty good.
Yes.
At ASCO, we saw data combining carfilzomib with venetoclax. The response rate looked pretty similar to that.
Yeah.
And so the question is, what is really being added by the bortezomib or the carfilzomib to venetoclax in a truly 11-14 sensitive patient?
Right, really good points. So how are you viewing
Yeah,
this?
no,
there is also the implication that there is a synergy with the proteasome inhibitors, right?
Right.
Both Velcade and Kyprolis.
Yes.
Yeah, no, I agree with Sagar. I mean, in fact, I do that work with Jonathan Kaufman. We're on that paper together. So I do think that in the 11-14, using it on its own or with Dex is probably going to be the first path for this drug to be available to us in myeloma.
Right.
But I do think, although this study didn't look at it in quite as much detail, that original Philippe Moreau study looking at patients who were truly refractory to bortezomib and then were given bortezomib and venetoclax together had a response. So I think it speaks to what you said right at the end, that there is something special about combining venetoclax and bortezomib or carfilzomib together, understandably, by their mechanism.
Right.
I'm not sure that we're quite convinced that that's the right combination. I hear your hesitation as well in how we use it, but I mean, I've had many patients who we put on the original trial, you know, it failed everything else. We're literally almost in that CAR T-cell realm heading towards hospice, and then we give them this pill, which thankfully most people tolerate really well, who went into a deep and a long remission. So it's exciting to have another option, another tool in the toolbox.
Right, and also one that is in this category of a precision medicine approach, which is really nice to see.
Yeah, and 11-14 happens in about 15% of myeloma patients. So it's not every patient by any means, but it's not so rare that there aren't a lot of patients affected by this.
So I think
and I do think it's worth at least realizing. So when we started to look at sensitivity, and I think this is a paper that's about to come out, we've looked at probably 80 or 90 patients at our center. There were a small subset of non-11-14s who were sensitive. It's not a big number, and I'm not sure it justifies combination in all the 11-14 negatives, but they were a subset that phenotypically looked different. They looked less like a plasma cell, more like a B cell, and they tended to express CD20. That's not universal.
No, but that's a little different
than
your average myeloma.
Yeah, that's right.
They're sort of myeloma with a dash of lymphoma. They have a little bit of overlap.
Right. So we're going to talk briefly about an additional topic here, which was touched on at the summit.
Just before we do, Brian, I will say
a final thing here.
Yeah, I was just going to say that for folks listening in, that there are other drugs too that we're getting very close to seeing potentially coming to myeloma, namely selinexor, which recently got a favorable review for its future, and then perhaps another CD38 antibody that you mentioned, isatuximab.
Is moving forward.
I'm presenting some work this week here at EHA for that, but I think that is getting a little bit closer. It still needs some time yet, but again, in this realm of wanting more options, it's an exciting time to see that we may well have 3 more drugs added to our regimen within the next year or so.
And then the approval of the pomalidomide Velcade Dex. Yes.
Very potent. We've been using that combination for a while, but it was nice to see in a big trial that it could be used, because we tend to think of pomalidomide as being used much later in the disease course. Here they were using it really at first relapse.
Well, and I think that's useful, particularly for a U.S.-based population, because many patients are progressing on Len maintenance. And so all of those randomized phase 3 trials comparing Len-Dex as the control arm, to me, and this was a source of great debate at the meeting as well, have less meaning. They're less valuable to me.
No, I'm with you, and so I think that...
I came under fire for making that comment, so I'm glad you agree with me.
So the PVD data are quite useful.
Having POM partners is really important in a post-Len patient.
Absolutely.
Agreed.
Okay. So cost of care, I'm not sure what we as researchers and clinicians can do about this, but it's a hot topic. Vincent Rajkumar debated it at ASCO. It was presented here by Jean-Luc Harasso with a European perspective. And so the average cost of a new drug is obviously really high, $150,000. I mean, there's a huge cost. The other thing that Vincent has emphasized is that in recent years there have been astronomical increases in costs for no apparent reason. And this rapidly rising yellow line is the cost of insulin, which has obviously been around for a long time. And so the cost of drugs, not just cancer drugs, is really out of control. And it's just hard to know what the future holds for that. But clearly, the costs are more than the system can bear. We do know that. And so at the patient level, it's all about access. I mean, the costs are limiting access, especially outside of the U.S., I would say, varying by country. There are very many different systems globally for this. And what are we going to do about this? What are the ways to improve access? Despite extensive discussion, do we look at patent laws? Do we look at how we handle generics? Do we have trials to support access? And certainly we're doing that around the world, is to try to enhance trial availability of drugs that are not approved. What do we do? And so I don't know what you would suggest. What as doctors are the most important things that we should advocate for, to try to help with this cost problem?
Well, I mean, I think the first step is just understanding a little bit of what you just shared. I think so often I wouldn't say we bury our heads in the sand, but we just say, oh, the evidence shows that this drug combination is the best. I don't really care about the cost, and we just go ahead with it. And we've done this throughout medicine, not just in oncology or in myeloma. So I think it's incumbent on us as physicians to be a little bit more aware of the bigger picture, and then of my individual patient sitting in front of me. After all this was raised the last few years, I'm very careful now. I ask every one of my patients, what is your copay for the drugs that you're receiving from me? And it's a huge variation. We have systems that try and help, and organizations and foundations that contribute money. But by September, it's pretty well all gone, it seems. So a lot of our patients carry a lot of burden.
But in that realm, I think it's important that if you have a patient who's on a combination, and the combined copays are becoming substantial.
Yeah. So I have a lot of patients, for example, who are both, not to pick on these drugs, but let's say they're on ixazomib and lenalidomide.
Yes.
And they'll say to me, doc, it's really hard to get both together. My copay for each of them is $400, $500. I can't do both. I can only do one. So I think the first step is us being aware of the issue to deal with our individual patient. And then, as you've mentioned, I think, Brian, we have to advocate at a higher level.
Yes.
I mean, this is why we have these debates, why we have these discussions, why Jean-Luc has been so active within Europe and some of us in the U.S. and other places trying to advocate for this, so that there isn't an uncontrolled rise in these drugs, that there has to be rationale. We have to look at the value of the drug and not just the fact that it happens to be approved by the FDA.
And one thing that Jean-Luc suggested is that we come together and create some criteria of value, and instead of delegating that by default to others, we should decisively assess the value as we see it.
Right. Yeah, I mean, and some of that will involve designing the trials. So there are different types of trials that are designed. One may be purely for the sake of registration and access, but others may be more for the how do you actually incorporate this into your daily practice.
Yes.
And I think it's important to realize that with almost every drug we've used, we've taken a few years afterwards to figure out where does it really fit into our practice and what's the right dose and schedule to give that may be very different from the original registration.
And so we don't have a trial for that, right?
That's right. That's right. Yeah.
And so, this was something, and also something emphasized by Vincent, is that to be thinking about that ahead of time, and Philippe Moreau from France brought that up.
Right.
In thinking about the trial design, is looking more at that practical level, as well as the approval. You need to get the drug approved, but you need that information to guide the subsequent therapy.
Right.
And also the reimbursement.
Right. And I do think it's important not to sort of, because one of the things that tends to happen when you have these cost-type discussions is that our colleagues in industry are sort of demonized for what they're doing.
Yeah.
And the reality is that they are at the table with us, particularly in myeloma, helping us to get these new drugs, these new innovations forward. And you can't get that for nothing. There has to be some sort of a trade-off. And so understanding what's mutually beneficial for everybody is part of the solution.
And at the summit, we did have the pharma representatives at the table. There was a round table. Well, it was actually a bit oblong, but anyway, they were at the table, and they were willing to discuss and be part of the discussion, which is a difficult and complicated discussion. But being at the table, very important.
Yes.
And I think one other thing I would add is it really is incumbent on us when we make conclusions based on prior trials about treating patients. For example, this idea that everybody needs treatment forever. We have to make sure that we look at that also in the vein of cost. You know, we think of long-term toxicity of these drugs. Oh, can it cause chronic diarrhea? Can it cause another cancer? Well, it can also cause what I call wallet toxicity, right? I mean, it can affect the patient. And so that's why I think our MRD discussion was interesting earlier, that, you know, if we end up having, you know, at least a small cadre of patients, and maybe a larger cadre with time, who reach a certain depth of response, we may be able to stop treatment. And paradoxically, that can actually affect costs, of course, because they don't need to be on a drug that costs $10,000 or $20,000 a month indefinitely for many years.
Yeah, so this depth of the response, the MRD testing has a lot of advantages. It could allow us to limit the therapy. It can shorten the length of the trials. It can speed up drug approval. And so I think that a lot can come from that, including impact on cost. Okay, so the final topic, which was a completely new topic, but a really, really interesting new approach to understanding the biology of disease and potentially treating the disease, is using the CRISPR gene editing technique. And we were very pleased to have a special lecture at the IMWG Summit from Ern Witta from UCSF, San Francisco. One of the first labs where they've started to use gene editing to knock out unwanted genes, for example, which is in the title of his talk here. And this is one of the first teams actually looking at doing that in myeloma specifically. And so starting to allow us to think about what can gene editing, precise gene editing, mean for understanding myeloma and potentially for treating myeloma. And Ern was starting from the ground up, educating us about the way that this works, and he had rather a beautiful video to show how this gene editing works based upon a natural biologic mechanism used by bacteria to defend themselves against bacteriophages. And so interesting to see that two really smart women were involved in the early discoveries for CRISPR technology and published the early data on this. And I think that just to move the discussion forward, if you're going to edit, obviously this needs to be specific. If you're cutting out genes, you don't want it to be cutting out genes that you need, so off-target is extremely important. For some diseases, it might be helpful to treat some of the cells. For cancer, obviously, you need to be able to treat all the cells or a majority of the cells. So very, very important to have a highly active method. You need specifically to be able to work with the plasma cells. There is an interest in the cancer biology space where if it's difficult to edit all of the cells, it might be helpful just to suppress selected genes. And so this could be a helpful way forward in the short term. And so Ern presented a lot of different ideas in the ways that CRISPR technology might be used. And so this is a new approach. Sagar, how do you view this? Is this early technology, exciting technology? How would you characterize it?
Yeah, I mean, I think there's no question that the CRISPR system has had a tremendous impact on the laboratory side of what we do already. And for the last 4 to 5 years, this has become a major part of many laboratories in trying to understand what are the genes important, for instance, in developing drug resistance. So
Right.
CRISPR screens for bortezomib resistance, CRISPR screens
Right.
for daratumumab resistance. All of those kinds of things I think are really important and have been done by some really key scientific people in the myeloma community.
Right.
The role that Arun really showed us was how can we potentially use this in therapeutic potential targets. And I think it's very early right now to understand exactly how we're going to do that. But the idea of being able to knock in or knock out certain genes, whether it's in a CAR T cell, so a cell that you've manipulated to over or under express certain things, or whether you're trying to go after a tumor cell and sort of normalize its dysregulated function.
Yes, or maybe upregulate CD38, for example.
Correct.
He gave that example.
Correct, yeah. Those are all things that I think we'll have to see more modeling, but it could be a really exciting concept.
Yeah, so, Joe, what do you think?
I you've summarized it well. I mean, myeloma is not as simple a disease as some of these others where the genetic pattern is a little bit more clear and we can always target that one area and repair it. You know, I think CRISPR will have a greater impact in some of the other diseases where the genetic pattern is a little bit more consistent or predictable or thought through or discovered where
it's
it's
already
more clear.
being used in some of the hereditary diseases
Correct.
like muscular dystrophy and sickle cell anemia, actually, where you can
you don't need 100% correction.
but you don't need 100% correction.
Right, and even some of that correction can really have an impact. And some of this is really, I think, it affect the pediatric population. We're going to see, there's even some, early work in utero trying to look at, affecting a child before they're born who may now not be able to have to be born with hemophilia or sickle, at least to the degree that they would have otherwise. So I'm not saying that it's not exciting. I think it's very exciting technology. And again, we want everything available to us. A major role for CRISPR myeloma, maybe down the line and a long way off, I think in the short term, almost like we thought of maybe CAR T-cell therapy 5 years ago and it was kind of just coming out. Let's wait, let's see how it evolves, and we may be able to apply it. But I was excited to have this as part of the summit. I think there's a lot of buzz about it amongst the individuals here for the summit because we want to know what's cutting edge. No pun intended, cutting. But we want to know what's coming and how this could influence our field.
Right. And I think, as you emphasized at the beginning, in the lab, I think it's really having a huge impact on our ability to understand resistance, driving mutations, for example, and we're excited to use this as a tool in the iStop-MM program in Iceland, where we're hoping to identify some key earlier driving mutations. But you identify mutations, but what do they mean? And so looking at that back in the lab, knocking the things in and out, you can start to understand the meaning of some of these mutations, probably multiple mutations that will need to be analyzed.
Yeah. No, I think it's exciting because it's a glimpse into the future. And I think that's always reassuring for us to see.
Absolutely. So, well, I think we're getting towards the end of our allotted time here. So, any last words? I mean, from ASCO, from the summit, moving into EHA, what is the hottest area that you think has emerged that is being discussed? What do you think is the...
I think probably looking at the abstracts from ASCO and again this week at EHA, I still think CAR T-cell therapy is probably now the greatest interest. To see from the BB2121 study, as we had now like over 40 patients presented in that study, as we start to see more of them come out, will there be a bit of a consistency around the progression-free survival and how people are tolerating it? So I'd probably say that's still the hot buzz, but there's still, as we've mentioned, a lot of other things, including the newer drugs, the selinexors, the venetoclaxes, the isatuximabs, that'll probably be the next ones in line for approval.
Right. I think without well, at our summit here, when we said who's going to go and discuss in which group, everyone was rushing for the CAR T door. I think that it was pretty clear that people were excited to learn more, but also, as you were mentioning, particularly Sagar, to understand better some of these things. What kind of cells are those? How many do you need? What are all of the variable factors related to this therapy, which we are just starting to scratch the surface, really.
Yeah. I mean, I think again, it's the half full, half empty kind of discussion. The CAR T cells are a great option for patients who don't have a lot of other treatment options. But I think it's important to also realize that there are a lot of patients that are doing remarkably well for a long period of time.
Absolutely.
And that's good news for everybody.
Yes, and we're seeing more of that, long survival with these different combinations,
Right.
which we talked about, especially DARA
Yeah.
combinations. Okay, well, I think that we've covered a lot of ground, and we appreciate the interest. We hope that this has been informative to patients and others who have been listening in. It's certainly been exciting at ASCO and here in Stockholm, and we look forward to an exciting rest of the year leading up to even more information at ASH in December. So thanks to you guys, to Sagar and to
Pleasure.
Joe for participating. We really appreciate it.
Yeah,
Thank
thank
you.
you.
Pleasure. Thank you.